Ladies and gentlemen, I shall present today some new epidemiological data to convince you that dyslipidemia, unrelated to LDL cholesterol, but intimately related to low HDL cholesterol and high triglycerides, is not only very common at a population level all over the world, but also related to future risk of myocardial infarction and stroke, which are so common worldwide. And this evidence is based upon two different data sets, the PROCAM data and a new case control study, the results of which are currently submitted to publication. Now, very short PROCAM. PROCAM now includes 50,000 participants. It is the largest prospective study in the world. It started about 30 years ago, and at entry into PROCAM, we do exactly 56 different variables which potentially relate to outcome. And outcome is MI, stroke, cancer, dementia, so a wide range of disease. 2/3 of the study population is males, 1/3 is females, and what I present today is based on a follow-up of a subset of approximately 23,000 adult male PROCAM participants and about 10,000 female adult PROCAM participants. Among the adult participants, in an average follow-up period of 12 years, among these 20,700 male individuals, 627 newly developed hard endpoints. And hard endpoints in this context is non-fatal myocardial infarction or death related to myocardial infarction. We had also many strokes, cancer deaths, other deaths, as you may see from the slides. But what I do is limit the information for purposes of time to myocardial infarction and restrict the comments to what we found related to HDL and triglycerides. Now, first, it is absolutely clear that low HDL cholesterol, and this is commonly defined as a concentration of less than 35 milligram per deciliter, that low HDL cholesterol increases risk of myocardial infarction at all levels of LDL cholesterol. So if a person has a low level of LDL, for instance, less than 100 milligram per deciliter to your left, he may have a threefold higher risk if low HDL associates with low HDL cholesterol. So the gradient between persons who run low LDL, less than 100, and HDL greater than 45, which is sort of normal, and other individuals who run low HDL, which is less than 35, and for instance an LDL cholesterol greater than 160, the gradient is 10.8-fold increased risk, so HDL clearly cannot be overlooked as an important risk factor. This is very interesting new data on event-free survival according to HDL cholesterol and triglycerides. Now, if you look to the upper part of the curve, these were individuals who at entry shared HDL values greater than 35 and triglyceride values less than 200 milligram per deciliter. If you look to the lower part, this is the opposite group, where HDL is less than 35 and triglycerides greater than 200. Now you see this dramatic difference in event-free survival. Quite important, the individuals who do quite well run higher LDL cholesterol values, 147, than the individuals who are at this very great risk for an event in a follow-up period of 10 years. Now, we several years ago developed a strategy for physicians to say that physicians should not over-focus on LDL cholesterol and statins, but that they should rather, in addition to LDL cholesterol, give emphasis to the lipid triad. And the lipid triad worldwide is defined as triple criteria, where the ratio of total cholesterol over HDL cholesterol, if it is high, like greater than 5, is related to a low HDL cholesterol value, less than 35, and where low HDL cholesterol associates with high triglycerides greater than 200. So these triple criteria are shared by 7.2% of adult male individuals at entry into PROCAM, and the incidence of new myocardial infarction in only 10 years is 15%. So 1 in 7 persons with a lipid triad without intervention suffers an MI in only 10 years. And the lipid triad occurs in 1 of 6 MI patients, so very common. So if you look again to these high-risk individuals, 15% risk, you may notice that LDL cholesterol in this high-risk group is only 144, while LDL cholesterol in the low-risk group, where the incidence in 10 years is only half compared to the high-risk group, that LDL cholesterol here is 176, so much higher than in the high-risk individuals. So this tells us an important story, and the story is that doctors clearly should not over-focus on LDL, but take into consideration both HDL cholesterol and high triglycerides. Now it is well known, and that was also seen in PROCAM, that the diabetic individuals, people who at entry into PROCAM are affected by diabetes, do not differ from the non-diabetic individuals in terms of LDL cholesterol value. So LDL in non-diabetic and in diabetic individuals is more or less the same. But what is grossly different is HDL cholesterol and triglycerides, where HDL is so much lower in the diabetic individuals and triglycerides so much higher. So this piece of data tells us from PROCAM, do not overlook low HDL and high triglycerides. So we did an additional and as yet unpublished case control study, and that study resulted in unique results as they again relate to the importance of low HDL cholesterol and triglycerides. So what we did here is to monitor first in 823 male individuals who were affected by MI, and blood was taken only within the first 6 hours after onset of clinical symptoms. So when a person develops heart disease and myocardial infarction, blood was taken very early. So the average age here of these individuals is 52 years. 65% of the MI patients were smokers. 1/3 of the MI patients were affected by diabetes. LDL cholesterol was 140. Blood pressure clearly elevated, 135. So what we did is to search in PROCAM, and remember PROCAM includes 50,000 people, to search in PROCAM for individuals who match for these major risk factors: age, smoking, diabetes, LDL cholesterol, and systolic blood pressure. And the matching was superb. So there was no difference here, statistical difference, in the matching criteria for these 5 variables. So we can ask the important question, what is the role if you normalize for LDL, age, diabetes, smoking, etc.? What is the role of HDL and triglycerides? So what we see here is that in the MI patients, the HDL is 44. In the matched controls, it is 52, so much higher, as you perhaps would expect. If you go for the triglycerides, in the MI patients at entry to the hospital, it was 153. In the matched controls, much lower. So we could do certain subgroup analyses, and first of all, ask the question, what is the difference, for instance, of low HDL cholesterol, here defined as less than 45 milligram per deciliter? Is there a difference in prevalence between the MI patients and the matched controls? So the prevalence here of this low HDL among the MI patients is 53%. So greater than half of the MI patients had this low HDL cholesterol value, but only 30% of the controls. And the odds ratio here is 2.57, highly statistically significant. Similar data for triglycerides. High triglycerides is more common among the MI patients compared to the matched controls. So what we did next is to do subgroup analysis among the low HDL and high triglyceride individuals. And the subgrouping was done in a tricky way. So we asked the question, why don't we look into certain LDL subgroups, for instance, individuals who run an LDL of less than 100 milligram per deciliter, plus HDL of less than 45. So 59% of the MI patients with this low LDL cholesterol value had an HDL cholesterol value of less than 45, compared to only 29% of the matched controls. So the odds ratio is very high, it's 3.4, much higher than in the other LDL categories. So low HDL cholesterol in terms of odds ratios plays a particular role among individuals who are affected by low LDL cholesterol concentrations. And here is the triglyceride story, where 49% of the individuals with low LDL cholesterol run moderate hypertriglyceridemia, in contrast to only 27% of the controls. The odds ratio is 2.6. So this data tells us that if a person has a low HDL value, for instance, he is treated with a statin, what is of particular importance for future affairs is low HDL cholesterol and high triglycerides. So we could do some further subgrouping and ask for combined criteria, low HDL cholesterol and or high triglycerides. Well, that's commonly defined as a low HDL high triglyceride syndrome. So if we go here into this data set, we here talk about persons where HDL cholesterol is below 45 and or triglycerides are greater than 150. So dual criteria. The prevalence of that condition among the MI patients is 66%. So 2 out of 3 MI patients are affected by these dual criteria. Extremely common. In contrast to the controls, the matched controls, where the prevalence is only 42. So matching here is very important. If you would not do matching, you might get any kind of data irrelevant for our question. So the odds ratio here is 2.6. So we could ask the same question here and do LDL subgrouping again. And the data were absolutely, unexpected. So 76% of the MI patients where HDL cholesterol was below 45 and or triglycerides greater than 150 were in this group of individuals where LDL is less than 100, in contrast to 38% of the controls. So the odds ratio here is 5, highly statistically significant. So the story again here would tell the physician, if your LDL cholesterol value is low, be particularly concerned about the major impact of low HDL cholesterol and high triglycerides for future risk of myocardial infarction. So the summary of these two stories is very simple. First, the PROCAM data demonstrate that low HDL and high triglyceride increases risk for myocardial infarction irrespective of how high LDL cholesterol it might be. And the case control data demonstrate, and they were done in men, demonstrate that the MI risk attached to low HDL cholesterol or high triglycerides, after accounting for other risk factors, diabetes, blood pressure, age, smoking, etc., is substantial and of particular importance in those individuals who run low LDL cholesterol values. And I'm very pleased to say, and I only know that since yesterday, that Professor Sachs in Harvard did something very similar, and he will, I think, present the data next, and you will see certain similarities between our and his data. Thank you very much.